The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today we have a very tricky situation to handle.
Our job is to ensure safe and effective care. In this instance, we have a situation where that may be compromised.
That's Professor Alan Sandford AM, the Director of Medical Academic Development, Regional Medical Pathway, Central Queensland and Wide Bay Hospital and Health Services. And I'm presenting him with a staffing problem that could have implications for patients.
We need to have courage and diplomacy. In this instance, both are required in spades.
In this episode, Alan will discuss what to do when age takes its toll on a senior surgeon's performance. In this scenario, we have a vascular surgeon who has been with the hospital for more than 45 years, holding senior positions, including chair of the medical staff. However, concerns have been raised about the value of his tutorials and the perception that his techniques are outdated. Patient volumes have decreased, and some cases have unexpectedly ended up in the ICU. So, an ageing surgeon with significant gravitas and pride in his contribution, but the registrars are talking. I started by asking Professor Alan Sandford what issues this situation raises.
It's a scenario that is actually all so common, really, and it raises a number of issues. But first and foremost, it raises the importance of maintaining respect, and that's a two-way street. So respect for the long-serving clinician that has that gravitas, but also it is respect for the processes involved in managing that. I guess the main message come important theme here is not letting this get so far down the track in the first place. What we often don't do is the maintenance of relationships, and that includes the changing nature of those relationships. We all change in our age and our capabilities, and to me this falls into the rank of medical workforce management, which of course the classic definition, having the right people with the right skills in the right place at the right time. But then it's also the managing of the relationship in a respectful fashion that maintains both dignity and the capabilities being maximised for a particular individual. In this instance, because it's got to this stage where there's already signs showing where safety is being affected, then it's then that we need to intervene in a more definitive fashion.
There are lots of parties involved in this. It's not just the surgeon. There's the patients that he's operating on, there's his partner, and they're standing in the community. There's his colleagues that are probably hesitant to address some of the issues. There's the trainees that you need to make sure they are trained in an appropriate way. There's the reputation of the organisation. Let's take some of these apart. First of all, what's your duty, I guess, to the patients?
As a medical leader, our role is also importantly to manage the relationships of the people around us, and that includes the relationships with our patients and families as well as those that are serving our patients, in this instance, this surgeon. So intervening in a way that is gracious and also courageous in managing this so that the reputation and the honour and the appropriate respect is afforded to the clinician, and that they don't find themselves in an invidious position in which they have in any way sullied their reputation, worse still, had an adverse outcome which has then led to patient harm.
What about their colleagues? Their surgical colleagues, but their nursing colleagues that work with them in the operating room, the anaesthetist, the nurses on the wards looking after their patients afterwards. What's your duty of care to these stakeholders, if you like?
Well, in a way, again, it's a two-way duty of care. The colleagues that this surgeon of 45 years has worked with will have seen him develop and age over this period of time. And the relationship is one that's dynamic, and it's a little regretful that there hasn't been something said to the surgeon prior to, and that the friendships that we have in our collegiate relationships as well haven't led to careful, quiet words up until now, so that it's got to the point where it's now become problematic. So we have a duty because it likewise reflects on those staff we work with, that they don't want to, one, see the surgeon find themselves in difficulty and indeed cause harm, but two, they also don't want to be mired within what could be a less than advantageous situation for the organisation. So there's very careful relationship management, and it is relationship management that I would encourage all of us to think about along the way before we get to this.
What about the trainees, the registrars that are rolling their eyes when they get assigned to their lists?
This is a really difficult point because, again, the trainees are usually the more astute amongst our team. They're very sharp in terms of their knowledge and developing skills. And they deserve, of course, contemporary practice. In this instance, the contemporary nature of this clinician is now questionable. And so, again, it leads to a potential compromise, and it leads to a diminution of the respect that we expect from our trainees, and indeed the trainees in their respect of the clinician concerned is compromised. So first and foremost, we need to maintain that level of guidance for our trainees.
So let's talk about the conversation that you're going to have with this surgeon. What does it look like? Who's going to be with you? How do you couch it? What are the sort of options that you would outline?
It's a really good question, David, and it's so situational in many ways, but I guess for me personally, as the DMS, I hope and I pride myself in maintaining close relationships, as in appropriately engaged professional relationships with my staff. And this particular surgeon of 45 years, I would take particular note because of the status they have within the organisation. He's been the previous chair of the medical staff. So I would probably approach this privately in the first instance and have that private discussion with the surgeon to see just how much I ascertain in the first instance as to their insight, as to whether they realise that they're starting to fade. If that wasn't forthcoming in the first instance and that insight was not there, then I would have with me the appropriate evidence and data to be able to present to the surgeon to say, well, look, I've been looking at this results and I wondered what you think. And again, in a gracious way, present the information to the surgeon and begin to explore options by which they are able to graciously withdraw from the situation which they have found themselves.
A lot of your evidence is anecdotal. It's the registrars that are just gossiping and whispering. Very hard to present that as facts.
Well, indeed, anecdotal information isn't facts. And so concurrently, I would begin to collect more hard evidence, more objective rather than just the subjective. And, those rolling of eyes and backroom comments are not helpful ever. They're not the sorts of things that we should be doing. And as medical colleagues, really as health colleagues, we're not terribly good at, of course, one of my major platforms is kindness. we're not very good at being kind to each other, and that includes kind during times that are difficult and during times where we have to have these difficult conversations. So in this instance, I think gathering information to present a compelling but compassionate approach to this now developed difficult situation is what I would do.
Where do you go if he has no insight and dismisses you as a young, incompetent, interfering?
Indeed, that would be a very difficult situation, and I guess one can't be dismissed in terms of the imperative of what we need to do. And in this instance, I would appeal to the clinicians, likewise respect. As the DMS, I expect a certain degree, irrespective of our age difference or whatever other differences. It's to do with the respect afforded to the office of the DMS, likewise to the senior surgeon. If that was the case and I got a somewhat disdainful response, I would probably call that out and say, look, this is really important. I expect the same sort of I will respect, and have that discussion. But at that stage would also ensure that I have the firm evidence that this is not just impressions and bad-mouthing, so to speak.
What are some of the options you'd explore with him so that he could keep his reputation intact but reduce the risk to patients?
Look, I think it relates to something that we should do every year when we determine what our scope of practice is, what it is that we do. And the performance reviews, however named or styled, that we have are rarely done in a way that is looking forward in terms of the true intent. But in this instance, we should have seen that with the annual reviews that have taken place. They may have been cursory because of the status of the person, so they've not really been meaningful. That goes to show just how important it is. In this instance, I would then look towards what are the remaining strengths. And indeed, with such seniority and experience, there is often further evolving strengths. And I would draw upon those. Where the weaknesses are, I would withdraw from them, as in I would decrease the things that he is no longer able to do capably and focus on what he can do both graciously and competently.
At what point would you call for an external expert to work with this person?
If the surgeon was not accepting of the evidence that you were presenting, then I think it goes to that stage to really present a situation where, look, I've presented all of these findings, but this has not convinced you that we need to do something here. And at that stage, I'd say, I think we need to call in. And it would need to be a particularly senior, as in when I say senior, a well-regarded peer that can have the appropriate status to be able to discuss the issues surrounding what's occurred here.
The ultimate sanction, I guess, is reporting the person to APRA. At what point would you do that? What would the sort of the triggers be that would lead you to think that this person needed to be reported?
And reporting people to the regulator is the last step. And indeed, it's a very traumatic process, and it's traumatic for the reporter as well as for the person that's being reported. And I have a high threshold that I use. However, that threshold isn't so high as to once it begins to adversely affect patients and families. So in that instance, I think that there would be, first of all, I would say that we're at the end of the line, that I've tried everything else with the surgeon, and then say I'm going to be compelled to do so. In that instance, if you still are not getting any leverage in terms of insight, then it's really just to advise the person that regretfully we've got to this stage. I have an obligation, set out the reasons for going down that path, and then proceed with it as diligently but also with as much compassion as one can muster.
We talked earlier about all the other people that are involved in this. There's the third in nurses that are watching, there's his colleagues that are watching what you're doing, there's the trainees that want something done about it. How much can you divulge to them about your conversations and processes?
One has to be very circumspect about divulging information to others around. That being said, those around have observed, do observe, and I think it would be naive to not acknowledge the fact that they are aware there's an issue. Going into the details, however, of that issue, I think is not appropriate without the permission and or the knowledge of the individual. The other party to this, which sometimes comes into it, and that is family. On occasion, there are colleagues that may not be part of your organisation but are friends. So peers that are friends, and sometimes appealing to them in a careful, confidential fashion can be a useful way to try and avoid that last step of reporting, which of course is a devastating endpoint.
One of the ethical challenges is the surgeons getting referrals from GPs for his surgery. If you come to the conclusion that there are parts of his practice that he's not really safe to perform, should you be telling the GPs that you have concerns so that they perhaps don't make the referrals?
I would find that difficult to do, and I don't think I would do that. If patients were referred to the surgeon that you knew were not able to be managed by that surgeon, there are other mechanisms by which you could avoid that situation, and that includes the management of the lists and what the surgeon's doing, certainly within our own organisation, and to some degree, well, I'm presuming that the surgeon's primarily with our organisation. So there is a way that you can modify and eliminate those risky procedures that way, but I wouldn't be, in effect, that would be besmirching the surgeon in a way that would be not gracious with the GPs.
We're talking about the opportunity to restrict his scope of practice. What about supervision? Would you require that another surgeon keep an eye on his practice?
These are all options. The credentials committee within the organisation, if it is appropriately constituted, and we need to pay attention to making sure we've got appropriate peers in that, can provide both the guidance, assistance and in effect, the safeguards surrounding the surgeon in the first instance. And so you would then negotiate with the surgeon about the alteration. Again, this should occur during the period of professional review, talking about that final end stage of the scope of practice and the position description, however described, which never usually gets looked at except when people are employed. It's at that stage you can say, look, how about we look towards decreasing activity in that particular area?
All right, let's wind back. You have the conversation with the surgeon and it goes really well. He says, yep, all right, it's probably time I stepped back. What's your organisation going to do to make sure that exit is as smooth and congratulatory as it can be?
I think that the incredible duty and service that this surgeon has done for the organisation, 45 years, the chair of the, it's celebratory. And so one allows a gracious alteration in activities, but celebrates and provides that level of acknowledgement that is so deserved. That way, reputations on all part can be maintained. So the fact that the surgeon has contributed, has been part of, and may have their picture in the staff, senior staff lounge, all those sorts of things, these are all perhaps quaint tradition in some ways, but it's all about, you mentioned really early on in a discussion, pride. And so the pride is twofold. It is for the organisation to have had him working with them and also for him and the service that he's been able to provide. And I would celebrate both.
A number of hospitals have emeritus type positions where they're welcome to come in and provide advice to their colleagues but not operate or admit patients. How does that role work so that he maintains his status as a respected peer, but you limit patients' exposure or risk to his failing competence?
Again, it varies with the individuals. That emeritus, and if there is insight and if there is indeed not failing wisdom, then the individual can come, but it's a titular role. It's a titular and or that gracious, I don't like saying elder statesman because that's sort of a bit, it's no longer de rigueur, but enabling the person to engage appropriately and having them come along to things. And on occasion, depending on the status, then those staff that remain will know what sort of things to ask. And again, it comes to the two-way relationship about not asking certain things that are to do with technical, particularly given there's indications that his technique, etc., is out. But the experience that he's had is irreplaceable. And drawing upon that, I think, is appropriate. And that's a nice, kind way to maintain the engagement.
We have a number of very senior clinicians who have pulled out of clinical practice involved in our audit programs and chairing M&M meetings, and they can be extraordinarily valuable. Nothing gets beyond them. They're able to ask extraordinarily hard questions without any comeback or repercussions, can provide an extraordinarily valuable role to an organisation. After the surgeon's retired, is there a role for support or off your books, out of mine?
Not the latter. I think there's certainly a role. And again, the history, the duty, the long-serving nature of the relationship, irrespective of whether they've retired, should be acknowledged. And on certain occasions, on various celebratory events at the organisation, and I've been in many, where those senior, respected but retired clinicians come to graduations and various events of the senior medical staff, or indeed celebratory events of the organisation.
Thank you, Alan. These conversations are very difficult because you're dealing with people whose life has been invested in healthcare and they've made huge contributions, but sometimes age has caught up with them. Thank you very much for your insightful observations.
That's a pleasure, David.
And that brings us to the end of this episode of Safeguarding Healthcare, where I was discussing how to handle and care for ageing senior staff with Professor Alan Sandford AM, the Director of Medical Academic Development, Regional Medical Pathway, Central Queensland and Wide Bay Hospital and Health Services. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.